Welcome to the AOA News Inside Track podcast. Today's Inside Track podcast is part of the QIPS Insights series, which is brought to you by the Quality Improvement and Patient Safety Committee. We'll hear from leads of quality improvement and patient safety projects, exploring how they got started, what worked, and key lessons learned.
I'm Dr. Andrew Harris, Chair of the American Urological Association's Quality Improvement and Patient Safety Committee. I'm back here today with Dr. Eugene Rhee, AUA President-elect, former Public Policy Council Chair, Chief of Urology for Kaiser Permanente Southern California, and Area Assistant Medical Director for Business Line and Finance for Kaiser Permanente San Diego. In a previous episode, Dr. Rhee and I spoke on the importance of joy in work and the Joy in Urology framework that Dr. Rhee is spearheading this year. And I encourage you to listen to this episode if you haven't already. Today, we will be going in depth on the Virtualist Model, a quality improvement initiative led by Dr. Rhee to help enhance joy in work from more of a workforce perspective. Can you tell us a little bit more about what is the Virtualist Model and how did you see this need? You mentioned that that call is an issue. Is this something that Kaiser, that the other urologists were coming to you and say, hey, this call is just making it so hard for us to function? What inspired you, like, this is going to be what I'm going to go after?
Yeah, Andy, I think what happened was initially, what really raised my attention was there was in our, there's a in order to be a partner, there's a 3-year track as an associate, and it stunned me that I had some associates who were calling me directly to say the call is just atrocious and it's hard. And I run my day job is running the Southern California. It's about 5 million members, 5 million lives. We have 13 urology departments, all staffed with about 200 urologists. The issue is that these are young folks who are really really saying, can you help us? And I thought, well, that's the nature of the business. I mean, just, like we all say, like, just we did it when we were young. Now it's your turn, right? And that can only go so far. And I learned a lot. I learned a lot about making sure that I listened and followed through with, well, what is it that we could do? What is the thing that's really causing people a lot of strife and angst? And the issue is really just not getting sleep. And then what we did was I created a strike force of folks, really smart urologists, and said, look, how can we make this better? And really what came out of that was a Virtualist program. The Virtualist program is a urology program that essentially looks at covering a broad area of Southern California that has an ability for one central virtualist that remotely from home, and this was born out of like the idea of the remote care, right? With the telemedicine we've already been doing. But then came COVID. And with that came all that explosion of doing remote visits. And I think that got people okay with handling things remotely in urology. That being said, then it's like, well, why couldn't you do a central virtualist to cover all the other local urologists in a hub and spoke fashion, where the central virtualist is a triage call that gets all the calls from Southern California and covers the local urologist, boots to the ground, covers all of them as far as that's concerned. So what happens is that the hospital, the emergency room, any call from the call center, anything gets diverted to one number. That one number is covered by the virtualist. That virtualist then essentially has workflows they're able to manage those things on the phone. And then if a urologist on call is needed, let's say a catheter issue, then the virtualist calls that urologist on call to bring them in, that they'll need to go in. In a nutshell, 85% of calls are managed by the virtualist. Only 15% are really escalated to local urologists. That's data. By the way, so we did this huge lit search to understand this. There's no urology call data. And so now, because we're an integrated system in terms of our communications, we're able to collate and understand just how much the volume is, and then really and now we're in manuscript form on this, but what we're trying to do is report what does a general urology call even look like, because I think that urologists across the country and the world, they need to have call data to really kind of explore with their hospital systems. As you mentioned, this is a systems approach, and really approach them with a collection of urologists to say, how best can we deliver the call. So essentially, that's the take-home message. It's simple in concept, however, execution, whole different ballgame. We realized really quickly on that a lot of cleanup needed to be in terms of there were people who still are on beepers, if you believe that. That people carry pagers, and we just had to standardize how do you communicate and get that even all done, which then led to like really kind of consistent communication with phone numbers as far as that's concerned. And that has really kind of gone into different phases. We've been doing this now for almost 4 years. And where it's gone into now is we've looked at sleep scores. So there is survey data that's made, it's called the Stanford Sleep survey, and you can kind of see remarkable differences in folks who were not who didn't have a virtualist and who have a virtualist as a backup, and how much quality sleep they have. And so those are kinds of the things that from high operational impacts, this is huge. This used to be just a physician wellness thing that we used to kind of do, but we can talk more about it. But we're looking at, and I know you're interested in this, is quality improvement. What have we done with the quality side? And I'm happy to talk about that.
Yeah, I appreciate those thoughts. That is absolutely phenomenal. And so I just want to reiterate some of that back to you to make sure I understand. So in this virtuous model, throughout that healthcare system, there's one urologist that gets all of the calls, and then they triage. So if you're the virtualist and I'm on call at hospital A, and hospital A has a phone call about a medication order that you can take care of, you take care of that, they don't wake me up. If there's somebody who needs a stent because they have an obstructed infected stone, then I would then get contacted and go in and take care. So I'm only getting called if somebody needs my hands to do something, which according to what you're saying happens only about 2 out of 10 times.
Exactly. You hit it on the nail.
Wow.
So like the only call, I'll add you to this, the only call you get at night, guess who? It's me. You don't
That
get
was going to be my question. Yeah,
you don't
so
get
that
it.
is phenomenal. So you're getting a urologist to a urologist call, which is likely a significantly enhanced communication of what you might otherwise received.
100%.
Yeah, that is awesome. So, uh, uh, several questions kind of come to mind as you talk through that, and you make it sound a lot simpler than it actually is, I'm sure, because there are thousands of people that had to then change how they function. It's not just the urologist, right? It's all of the nurses and the ERs and all throughout this healthcare system. Can you walk us through a little bit about how you approached getting those people to change behavior? Was that just, hey, we're just going to change the number in the call system? Or was there a little bit of, hey, we got to go talk to some people and make sure they're okay calling someone who is not at this hospital?
Yeah, so a very sophisticated question right off the bat. What happened was we conceptually we had the architects, we kind of created the plan. But before we implemented anything in terms of execution, it was, really kind of understanding what are going to be the barriers of entry. The barrier of entry, for sure, just like you said, is that number one is a consistent communication cascade and network that everybody agrees on. That's number one. So then that led to, well, the emergency rooms of each of these medical centers, they have a different workflow of how they reach a urologist. So that had to be cleaned up. And so that was a collaboration with the emergency room leadership, meaning I had to bring so the chiefs of all the emergency medicine departments, I had a clear presentation about what we're going to do. Okay. So change management. So it's about developing a sense of urgency. You got to develop a sense of urgency. And I was explaining to him about, the kind of things that were happening in urology that were just simply like, we need your help. And so emergency medicine really kind of understood very quickly. And their benefit was they were going to get a virtualist who was going to answer the call immediately. And also in emergency room, what you discover is they hate. So this is between 9 p.m. and 7 a.m. Okay. So 9 p.m. to 7 a.m., you can imagine, right? At midnight, 1 in the morning, when you're the emergency room doctor calling a urologist, how I can't, I mean, you can just imagine how challenging that conversation is, right? They're just in a bad mood. And so this was like, hey, I promise you that you're going to get a call from the virtualist, right? Johnny on the spot. We're going to answer the call, but we're going to be a service-oriented business. We're basically going to be your urologist and be able to escalate. You don't have to escalate. We will escalate. And so the virtualist, that was the enticement, if you will, that the emergency medicine quickly saw. Hospital medicine, also another group that we had to do. In addition, the nursing staff, so executive nursing staff had to be on board with understanding this so they could cascade through the hospitals in regards to how this is going on. As well, we also have transfers. We have, those kinds of issues, KP on call, things that are already centralized for patients who can call a nurse. But we all, again, it's really a communication dynamics that have to be addressed as far as how to execute this plan. Once everybody understood the concept, then you have a target date. You have a target date and agreement that you really kind of follow through with a team. And so the other part of this is that this is a real team effort of virtual, scheduling. It's also you have to pay, so the virtualists get paid to do this. Okay, and that was also discussions with the hospital administrators about, just justification of a business case as to how this would work. And so that was also part of this whole discussion.
What would advice would you give other urologists if they were going to go have this? What data do you have that would be supportive of the money is worth what we're going to pay somebody?
Yeah, Andy, I mean, the data is critical. So, this isn't like you can't go to the well with hope and a prayer. That's not going to get you anything, but and I think you need to really understand your denominator. You have to look at the amount of calls that everybody's getting. You have to look at it from a standpoint of quality. And so, like, I just had a call with Eastern Washington, a collection of urologists who are really wanting to move forward in doing this in their huge community of Spokane and rural Washington. They are trying to understand how there are transfers of patients for just a catheter that are being air ambulanced, right? These are things that are these are normal things that are happening out there, and at an enormous cost to the system. The point is that I've asked them, you got to look at all these data points, bring them in as at what time, when you're getting called. So in other words, this beeper call, so to speak, you kind of have to look at like how often you're getting called and why you're getting called, and looking at the quality issues and the safety issues that are also used as cases to document. Now, when you get all that together, then you go to the hospital administrators to talk about, how, the centralized call would be, executed in the system that you have is what are the benefits and the return of investment. Okay. So the money would be about like paying the virtualists, right? Um, the return of investment would be what are the cost savings that occur from having a urologist who's on a rotational basis at your beck and call to make sure that a transfer is legitimate, or that you need, how do you cascade and transfer patients to the right people at the right time, whether it's pediatric urology or whether it's somebody where you don't have IR, but you got to transfer it to the University of Washington. Those are kinds of things that are kind of built into this business case plan. And you kind of, from there, you have to really uh, show how the communication network would work. how the communication network would work and how the EMR systems would work for continuity of care as well. To get, now we have care everywhere. We have different ways that we can actually communicate in regards to different EMRs. However, you can imagine, I know the listeners are saying, well, that's Kaiser Permanente. You're in a vertical organization that's all, a single entity, if you will. But this can be done. This is done at UCLA, by the way, by the residents. The residents, because of the satellite coverage that's happening at UCLA, they adopted this. And so they have in their system a way to where the residents are now doing a virtualist model in this way. So, this can be done on the outside. I know Houston had been looking at this. They're still looking at massaging the business case around it. But I think that this has a lot of potential for urology practices.
I think this is something we could work on unpacking in a significant amount of time. It is so impressive that it's been going on for 4 years, which is likely some good evidence that it's working well, because someone wouldn't pay for it if it wasn't, and the urologist wouldn't do it if it didn't make him happy. So that is fantastic. What is one thing that just surprised you from everything? You're like, you know what? I didn't see this coming, but it's really fantastic that it happened.
You mean from the call situation that we had?
Yes, from
Yeah,
the
great
virtuous
question.
model.
So this is what happened. So I'll tell you on the quality side, and then I'm going to tell you on the human side. On the quality side, what had happened is that we have had standardization of protocols. So we now have data on like what are the most common calls that people get in urology. That's gross hematuria, acute stone management, and urinary retention. With those three protocols, we've engaged the urology chiefs, the hospital and emergency medicine chiefs, and developed and refined protocols for these top urologic conditions. So it's a workflow. The second thing from a quality standpoint is you'll find this very interesting. We found a reduction in the median length of stay in between 2021 and 2025, where we saw length of stay decreases in the emergency rooms across these pilot sites. And that creates savings of close to $1 million a year. So what we're seeing is real money wrapped around also, folks who are waiting in the emergency room. And so the improved length of stay is really about urology dispositions that are happening quickly. The other part of it also is, as we had said, was, the human side. The human side is recruitment and retention. So what's a thing that I didn't also account for? Again, I was doing this program just to get people to sleep better. So I've told you stuff on the quality side as a systems approach, but on the human side, it's about recruitment and retention. So the recruitment is about these youngsters who are now joining who've heard about our program, and they're wrapped around, wait, let me get this straight. So I am covering call, but I have a virtualist in front of me. And that has been the testimonials that we get from what we call these associates, things like, these are the biggest reasons I joined. The program has been one of the factors that was my decision, to join. And the virtualist call coverage was definitively a reason why I wanted to join. Now, from a retention standpoint, I have people who are retired who want to continue to stay in this model of care. So in other words, they're retired, but they still want to do per diem work. So they're willing to work this model because as a virtualist, you're not going to the hospital. You're managing this from home. So they're able to do this and, post call the next day. So if you're retired, you have that already built in. I know that listeners will ask, well, what do you do post call? A lot of guys will have a lighter schedule for the morning. They do remote work. So we'll do a lot of video visits and telephone visits in the morning of post call for virtualist care. So that's the answer to your question.
But I appreciate those thoughts. Congratulations on such wonderful work. I think from a quality improvement perspective, the way that you approach this was fantastic. You had a good understanding, and the data supported you had a problem.
Yep.
And you had an intervention designed to mitigate said problem. And then you followed the data to see if your intervention worked. I mean, that's like QI gold right there. I mean, that is fantastic. And then from the burnout perspective, I so much appreciate doing something that is complex, right? And you really understanding the reasons, again, data supported reasons why people are struggling to get up and enjoy what they do every day. And instead of focusing on that human, focusing on the system to allow the urologist to function in a way that makes them appreciate what they do. So really just so much appreciate this work. Thank you, Dr. Rhee, for this engaging discussion. Thank you to the audience for listening to this podcast. Be sure to listen to a previous episode about joy in work for urology and the Joy in Urology strategic framework, and be on the lookout for new episodes from our QIPS Insight podcast series.
This has been QIPS Insights, an AUA News Inside Track podcast brought to you by the Quality Improvement and Patient Safety Committee. For more information about AUA's quality improvement and patient safety efforts, visit auanet.org/quality.